Hello, everyone, and thank you for joining our webinar, Cutting Edge Issues in Physician Compensation today. Before we get started with the content, I'd just like to go over a few quick housekeeping items. Please note that this presentation has been recorded and is for informational purposes only. You should consult a professional advisor for specific medical, legal, financial, or other advice. Please take a moment to look at the screen and review this notice. This webinar is part of the AMA's Private Practice Sustainability Initiative. Private practice is an attractive option for physicians seeking the freedom and the independence to practice in a setting that allows them to provide personalized medical care for their patients and is inclusive of practice owners, employed physicians, and independent contractors. Private practice is an important part of the healthcare delivery landscape, and it has been under intense pressure for several years. The COVID-19 pandemic has exacerbated existing concerns of physician practice owners, but has also created opportunities to change and improve healthcare delivery to patients. We do have some upcoming content as a part of this initiative, and there'll be that will be released throughout the rest of the 2021 year, and there'll be more to come in the first part of the next year. The AMA currently has a private practice sustainability toolkit live on the website, which aggregates a number of the AMA's existing resources intended to support private practices. It'll be updated with the new content throughout the remainder of the year, and you can visit the page, which is our Private Practice Sustainability Toolkit, to learn what resources are available to you. Finally, I would like to introduce today's speakers. Today joining us, we have Gina Gunville and Neil Shaw from the Polsinelli Law Firm. And with that, I would like to turn it over to Neil, who will be starting us off and bringing us through the content today.
Okay, thank you, Megan. And I'm excited to be here to talk about cutting edge issues in physician compensation, an important topic given a lot of disruption and a lot of interesting change in the last year or two, especially. Next slide, please. So just to tee up the overall topic, historically, physician compensation has been obviously of incredible interest to physicians and to practices, but somewhat simple in a overall conceptual level. Essentially, you would look at all of the revenue flowing into a practice entity, whatever kind of practice entity we're talking about. You would then deduct the overhead and the actual expenses of running the practice, everything from salaries of non-physician staff, equipment investments, other kinds of overhead costs. And then you'd have an amount left over that would be distributed to physicians as compensation, typically on the basis of some sort of productivity measure. A lot of variation, a lot of complexity in that very general framework, but frequently that was the framework we were looking at and that virtually every practice has operated under historically. What's happened the last year or two and heading into 2022, as well as the prior year of 2021, is a number of different factors that have come together to create something of a perfect storm of physician practices looking back at their compensation models and rethinking whether or not the models that they've implemented really fully capture their strategic goals. This isn't a comprehensive list, but just to summarize some of the most important factors here, we've seen changes in federal payment rates, particularly the Medicare physician fee schedule for 2021 and the proposed schedule for 2022 would have implemented and would implement some very significant reductions for some specialties and slight increases in other specialties, reworking the way that traditional productivity measures have historically applied. The COVID-19 pandemic, ongoing effects on the entire healthcare system, particularly with respect to volatility in patient volumes. Going back to 2020, there were very significant drops in volumes. We've seen recoveries in some specialties, in some regions, but there are still often increases and decreases in volume, in part influenced by severity of the pandemic in any particular region. That has an impact on productivity as well. So traditional, say, WRVU type models or productivity-based models may have an impact and may not fully reflect the value that a physician is bringing to the practice as a whole. That kind of volatility also has an impact on payer mix, as there are changes in patients' employment status, enrollment in governmental payers, and other kinds of practice finance implications. We're also seeing additional payer willingness to engage in non-fee-for-service reimbursement. This is an ongoing change. It's been rolling out for the last decade or so. But in the last few years, particularly as fee-for-service was impacted by the changes in patient volumes I just discussed, I think there's been an increased willingness, both on the practice side, but especially on the payer side, to rethink some of these models and bring in concepts of capitation, shared savings, other kinds of value-based and non-fee-for-service models. Changing use of technology, again, an impact of the COVID-19 pandemic, but also something that predated the pandemic. Increased utilization of telehealth, increased utilization of remote patient monitoring. Many of these new technologies that allow physicians to meet patients where they are in more convenient settings. The challenge is many of these were pushed into the mainstream on a very quick emergency basis. In many cases, reimbursement is directly dependent on temporary emergency authorizations. And so that makes predicting the long-term practice finance impact a little bit difficult. And it puts some question marks around the ability to take this revenue attributable to telehealth or other kinds of technologies and turn it into a sustainable compensation package. Finally, burnout is an ongoing issue. It's something that has predated the pandemic, certainly, but it's something that has really been supercharged by the pandemic. The incredible efforts of physicians in responding to this once-in-a-lifetime public health crisis have been very inspiring, but they've also been impactful on causing practices to look back and think about how they can actually engage with physicians and retain physicians in the face of all of the challenges that are facing private practice. And then I'll just quickly lastly say, there have been changes to fraud and abuse rules as well as additional interpretations, which we'll talk about in this presentation as well. So I'm going to turn it to my colleague Gina to discuss some of the roles of attorneys here. As you may have noticed, Gina and I are both attorneys. So why are a pair of attorneys talking to you about physician compensation? I'm going to turn it to Gina to give some additional context there.
Thanks, Neil, for that overview of current issues affecting physician compensation. And as you mentioned, we want to set the stage a bit as to how attorneys can work together with physicians to help you through the negotiation process, essentially, in determining, the best physician compensation packages that might be available to you, what opportunities might exist now with the changing landscape, and just in general, kind of set the stage a bit further. We're not valuation consultants, and so therefore we don't offer opinions on the overall amount or range that would be appropriate to be paid. And we're also not necessarily involved in facilitating payment at the maximum potential payment amount, but we are able to help identify, through discussion with our clients, the various aspects of compensation that, are running through an arrangement and assuring that the documentation matches with, the intention of the parties and the services that should be compensated for, and also to help with, evaluation of the overall regulatory compliance picture and analysis with regard to the aggregate overall compensation. Beyond purely compliance-related advice as well, we really are at the table in assisting with negotiation of mutually agreeable terms for parties within an arrangement, the how and when items that tie to compensation will be evaluated and reported, for example, with regard to meeting certain quality or performance metrics. We also want to assure that the agreed upon compensation method, as I mentioned, is accurately reflected and is able to actually be put into practice, that the documentation reflects what is actually done on site after the attorneys are no longer working with the documents, that this agreement that you've entered into is able to be administered with ease and a relatively lower level of burden than one that perhaps was not poorly drafted or vague in certain areas as well. In general, we're just looking to be forward-looking in how we put into place documentation too that can serve a physician client, both with regard to opportunities now and then also provide touch points throughout the term to come back and renegotiate terms, or if a dispute were to arise, really clarify those provisions as well that a physician group could take advantage of in modifying or exiting an arrangement as well. So now Neil's going to talk a little bit more about some common legal requirements that come up in the regulatory analysis of physician compensation. Next slide, please.
Great, thanks, Gina. So as Gina said, we're going to get into some of the specific legal requirements that we're going to have to analyze and work around or comply with in the process of developing a new physician compensation model. So there are a lot of creative practice administrators out there, physician champions out there, evaluators out there coming up with new compensation models right now. But the role of attorneys in a large part is to ensure that these models are, as Gina said, accurately reflected in the documentation, accurately implemented going forward, but also compliant with this large regulatory framework. The fact is, physician compensation is one of the more regulated industries, in our economy, and that means that there are a number of different legal regimes at both the federal and state level we have to keep in mind in developing a new compensation model, especially. So this isn't going to be a deep dive on any particular one of these areas, but it's important to, I think, keep the overall regulatory framework in mind as you design new compensation models. So first and foremost is a set of fraud and abuse laws that can have significant financial impacts and really kind of pose the first line of compliance for really any healthcare entity, but particularly physician employers. As examples, you have the federal Stark Law, Anti-Kickback Statute, Civil Monetary Penalty Law, and the Federal False Claims Act. There are also similar but not identical state rules echoing all of these federal laws as well. They vary from state to state. The specifics vary from state to state. So it's important to work with qualified and experienced local counsel in thinking through how this suite of laws is going to apply to any particular arrangement. Many states also have requirements around the corporate practice of medicine, which limit the ability of a non-physician employer to design certain compensation, to develop certain kinds of care protocols, to instruct physicians in particular ways. In many cases, non-physician employers have real limits in the ways they can actually incentivize or affect physician behavior. There are also often payer policies. Payer policies are often a major driver of the way that compensation models are set up because they reflect the actual revenue flowing into the practice entity. So that could be anything from coverage, reimbursement, and documentation rules. It could be things like supervision rules, things like risk adjustment, data collection. There are all of these moving pieces in the payer agreements and policies that may directly impact the structure of a novel physician compensation model. And then there are other issues that may pop up depending on the actual relationship of the parties and the posture of the arrangement. So tax implications, if you have a tax exempt employer, that may have implications in its own right, competition policy or antitrust policy, depending on the specialty and the kind of employer again. And then in some cases, we've seen issues pop up just based on benefits and the ability to jointly negotiate a package that's acceptable to physicians. Next slide, please. So I'm going to focus a little bit on the fraud and abuse requirements because, as I said, they're often the first line of compliance questions, and they're often the thing that most directly implicates and affects especially new physician compensation strategies. The two laws that frequently come up in developing compensation strategies are the Stark Law and the Anti-Kickback Statute. Again, these are both federal laws. There may be similar laws on the state level. Stark Law is all about compensation relationships, specifically between physicians and entities that the physicians refer to. And it's limited to defined designated health services. So it's a narrow set of services, historically kind of called ancillary services, as well as hospital services. Stark is all about the form of a relationship. So is there a financial relationship of some kind between an entity providing these designated health services and a physician? If there is, and if the law applies, there are some questions around exactly when the law applies. That's very fact specific. But if the law applies to a particular arrangement, an exception has to be met. If the law applies and an exception is not met, you potentially have a violation of the Stark Law in that case. If that occurs, the penalties are primarily civil. There's financial penalties. They can be very large. They can include Medicare reimbursement or recoupment, as well as financial penalties above and beyond the refunding of Medicare reimbursement received by the entity as a result of the referrals made by the physician. So large financial penalties, but usually restricted only to financial penalties. The kickback statute, by contrast, is a criminal law. It prohibits the knowing and willful offer, solicitation, or payment of anything of value to induce referral or certain other kinds of degeneration of business payable by a federal healthcare program. So where Stark is all about the form of the relationship between a physician and another entity, kickback is all about the intent of the parties. Why was something paid? Why was something of value being provided to a particular physician? Unlike the Stark Law, which requires compliance with an exception if the law applies, the kickback statute provides a couple of different options for compliance. There are a number of safe harbors that will protect an arrangement if the arrangement fits every element of a safe harbor. But the government has been clear that the kickback statute's application really depends on the intent of the parties. And again, why was anything of value offered, paid, or solicited? And so while the safe harbors are helpful, they're not necessarily mandatory in the sense that the Stark Law is. Finally, as I said, kickback is a criminal law. In addition to fairly large financial penalties, depending on the facts of the violation, the penalties can rise up to possible exclusion from federal payment programs and even imprisonment for violations of the law. So much more severe penalties, but also limited to a particular kind of conduct in a way the Stark Law isn't. Next slide, please. So this chart really puts the two major laws side by side. It illustrates the differences between the application of the two. Again, you see the scope of the Stark Law versus the Anti-Kickback Statute on the first row. Referrals of certain services made by a physician to an entity with whom he or she or an immediate family member has a financial relationship. That's a Stark Law. The Anti-Kickback Statute, again, covers intent-based or violations. The Stark Law is limited to certain kinds of services. Now, this isn't a complete list, but it covers the issues that we most frequently see pop up. So imaging, lab, drugs, your kind of classic ancillary services, physical therapy, occupational therapy, speech therapy, home health, durable medical equipment and prosthetics and orthotics, inpatient and outpatient hospital services. Those are the areas where we frequently see Stark compliance matters kind of bubble up. And a kickback statute doesn't have that kind of limited scope. It covers anything payable under a federal healthcare program. Now, when we're talking about compensation, as I said, there are a number of exceptions and safe harbors available under these laws. But for compensation, what we really care about is payments for services. And so there are a couple of specific exceptions and safe harbors we would look at. In particular, under the Stark Law, there are a set of exceptions for employment and for personal service arrangements. There are a couple of exceptions that can apply on the Stark side. Again, you have to meet each and every exception each and every element of an exception in order to be protected. There's also a set of special rules for physician group practices. On the kickback side, there's a very broad safe harbor covering many kinds of employment compensation arrangements. There also is a safe harbor for personal services, but again, you would have to meet all of the elements of the safe harbor in order to achieve protection. Or again, on the anti-kickback side, the analysis would then turn on what was the intent of the parties in paying that kind of service-based compensation. Next slide, please. So this slide summarizes some of the requirements that we have to think about as we develop new compensation methodologies under these laws. And I'm not going to walk through this in detail, but I just want to call out a couple of important things. The first thing is you can see the level of regulatory complexity is directly driven by the relationship between the physician and the employer or the contracting entity. There's much more flexibility for direct employment. There are still some things to think about from a Stark perspective, but on the kickback side, you have the maximum amount of latitude so long as the employee is a bona fide employee. On the other hand, these kinds of independent contractor relationships, and that's whether that's between a practice and a physician, or between, say, a hospital and a physician practice, or some other entity and a physician practice, those kinds of contracting relationships tend to have higher requirements. And in particular, we see issues around the fair market value, commercial reasonableness, and volume or value considerations. And these are things that, particularly with newer compensation methodologies that may not have as much of a track record, we see these often become challenges as parties are attempting to implement newer compensation strategies. The last thing I'll say very quickly here is Stark in particular offers a fair amount of flexibility for productivity bonuses as long as they're based on personally performed services. Group practices have a little bit of additional flexibility, and we'll talk about that in a little bit of detail here in a moment, but I do want to flag that the regulatory regime gives the highest level of flexibility to an independent group practice that is composed of physicians and operated as a physician practice. So I think that's an important element to think about in thinking through future compensation methodologies. Next slide, please. So I'm going to quickly touch on a set of regulatory changes that were made in December of last year that have really loosened or clarified the impact of the Stark Law and Anti-Kickback Statute. These include changes to definitions. They include some interpretive changes. There are deeper dives on a lot of these materials available through Polsinelli and I believe through AMA's materials as well. But we're just going to touch on some very specific elements that directly impact novel physician compensation arrangements. So first, as I was saying, fair market value, it's an important element of many of the exceptions and safe harbors. It's often just a core feature of setting the compensation arrangement in the first place. Historically, it's been a challenge because fair market value is determined based on what reasonable parties in a similar position would be willing to pay. That is easy to determine in some cases, for example, through national surveys, through market-based surveys. You may have good data and good information about typical compensation relationships, say a WRVU or productivity-based arrangement in your market. But as you move away from that structure and you enter into something like a value-based structure or a capitated structure or something along those lines, it may be harder to find these comparable elements. And it may be harder to find kind of what a reasonable party would pay when you may be entering into an entirely novel relationship. So the regulatory change made in this case by CMS to the Stark Law regs was really simplifying the way that the fair market value methodology worked. So fair market value, it's now defined as the value in an arm's length transaction consistent with general market value. General market value is the amount that would be paid by parties entering into a service arrangement as a result of bona fide bargaining between well-informed parties that are not otherwise in a position to generate business for each other. The CMS did also clarify that that needs to take into account the legitimate business goals unrelated to referrals of the parties. So that provides a little bit more space to be able to point to what the parties are trying to achieve in terms of clinical integration, improving patient experience, improving patient care, reducing costs. Some of these other goals may provide a basis for arguing that compensation is fair market value, even if you don't have other comparable data that you can point to. Next slide, please. Similar concept in commercial reasonableness. This is a term CMS had not defined in the past. It's part of many of the exceptions. CMS now specifically says commercial reasonableness exists if the particular arrangement furthers a legitimate business purpose of the parties to the arrangement and is sensible considering the characteristics of the parties. Importantly, they clarify that an arrangement can be commercially reasonable even if it does not result in profit for one or more of the parties. Next slide, please. So changes to the group practice rules. As I said, group practices have more flexibility than other kinds of employers or physician contracting entities. Most importantly, they have the ability to distribute revenue in a way that other kinds of contracting entities can't. They have the ability to distribute revenue arising out of designated health services as a productivity bonus based on personally performed services or based on services billed incident to a physician's services. They can also distribute DHS revenue as a profit share based on overall DHS profits or a component of at least 5 physicians. There have been lots of questions around the kinds of components that a practice can set up. So for example, if you've got 100 physicians, how are you allowed to split up those 100 physicians into subgroups of 5 or more? CMS clarified that those groups can't be based entirely on the type of DHS. So for example, you can't say this is our imaging pool, this is our infusion pool, this is our PT pool. But you can still base it on specialty and location, as long as that's not just kind of a hidden way of getting to a DHS-based allocation. And I think one of the most important clarifications that CMS made is, short of that requirement, they're giving a lot of latitude to practices to identify which groups of 5 or more they'd like to keep in place. And so we can talk about examples of these kinds of subgroups, but I think that's an important clarification that practices, large practices especially, have the ability to tailor subgroupings to reach the kind of goals that they're attempting to achieve. Next slide, please. So I'm going to quickly touch on the public health emergency. This is unique to the circumstances of dealing with COVID-19. Unfortunately, sitting where we are at the tail end of 2021, the pandemic doesn't seem like it's, going away imminently. So it's possible that other kinds of regulatory flexibility will stay in place. These were temporary modifications to the Stark Law designed to allow physician employers or entities contracting with physicians to quickly address some of the changes to the marketplace that we talked about a little bit earlier. In order to use the waivers, they must relate to COVID-19 purposes. This is not a comprehensive list, but it does reflect that CMS explicitly intended to allow the waivers to cover interruptions or challenges to the ability to contract with physicians during this period of time. Next slide, please. So this is a set of the flexibilities that are available in cases where the waivers apply. Most importantly, and I think one of the ones that we've seen used frequently, is the ability to pay above or below the amount that may be fair market value for personally performed physician services. But there's also the ability to offer rental relief, change the rate paid for using premises, using equipment, or providing non-monetary compensation. Next slide. Thanks. So this is a list of scenarios, and I'm not going to go through these in a ton of detail, but I just want to raise these as food for thought about cases where we're seeing compensation strategies run across legal challenges or compliance challenges. And so examples include moving away from per RVU based reimbursement strategies, or keeping existing RVU rates in place for at least some period of time, despite the cuts to specialty reimbursement. I think there are arguments that that can be supported as long as you have other evidence of fair market value and commercial reasonableness. Hazard bonuses, other kinds of incentives to improve physician satisfaction, during the pandemic. Making assumptions about forward-looking reimbursement, even though things are very up in the air right now around what reimbursement strategy looks like. I think that physician practices have a fair amount of flexibility in saying we're making reasonable determinations about what the future looks like for purposes of setting compensation. And then finally, the supergroup concept with a variety of profit sharing pools. As I said, CMS has been clear that there is the ability to be a bit flexible about how you're defining those pools. So I'm going to turn it to Gina now to talk about a big topic, which is value-based care.
Thanks, Neil. So during our time today, we wanted to make sure we also cover the continued push by both commercial and governmental payers towards adoption of and engagement in value-based care models and how that's impacting physician compensation. Many value-based care models involve incentive payments made from a payer to an entity that employs physicians. For example, with shared savings that are coming and being distributed directly to a clinically integrated network, and then flowing through that network to a multi-specialty participating practice. Or, for example, via capitation for professional services that's made by a payer to a hospital employer, again, flowing through to the physician. Value-based care also can be experienced by physicians through compensation withholds under their compensation arrangements that then are earned back by a practice through meeting certain cost savings targets or other metrics as well. So overall, what we've seen is when risk-based payments to entities are converted to payments at the individual physician compensation level, that those payments are still usually based on a fee-for-service model. However, just recently, there have been some regulatory changes that are increasing flexibilities for value-based care models and for compensation strategies to benefit physicians in a different way, moving away from fee-for-service. And we view this as creating potential new opportunities for physicians at the negotiating table as well. Just recently, in November of 2020, the Centers for Medicare and Medicaid Services and Department of Health and Human Services came out with a set of new regulatory rules that finalized some new value-based payment exceptions under the Stark Law and under the federal Anti-Kickback Statute to create some of this additional regulatory flexibility. Next slide, please. With these new final rules, there's this framework now for entering into value-based arrangements based on the level of risk that an entity or a group of participants are willing to take on that are participating within the arrangement itself. There's also now a new consistent vocabulary that's being implemented with regard to developing and participating in value-based arrangements. And we see that continuing on as well. There's a very clear signal, an interest in adoption in this consistent vocabulary. At a very high level, the new rules create exceptions that can fall into three categories or tiers of value-based arrangements. The first tier we call a low to no risk type of arrangement. The second tier is one in which participants in a value-based enterprise would be willing to take on some level of meaningful or substantial risk. And the third tier is really for participants that are ready to take on full financial risk. This framework gives opportunities for organizations to enter into an arrangement based on their comfort level with taking on a relative level of risk or no risk, and really begin to engage in value-based payment. Also, the goal here too is you can start to take advantage of an opportunity in a lower tier as a way to prime yourself to see if you're able to engage in a higher risk tier later on as well. In order to participate, we work with our clients to evaluate, how participation is going to further a value-based purpose, whether you're aligned with other providers under the arrangement as to what the overall outcomes to be achieved are, looking at whether or not the participation in the safe harbor or the exception requires you to adapt through expansion of additional internal resources, both in terms of personnel, additional physician time, or building of additional IT infrastructure to participate. And really understanding how you're going to monitor your progress towards this and document your achievement of certain aims. Some of these exceptions and safe harbors, depending on the tier for participation, have pretty onerous reporting requirements and duties to adjust your behaviors as well if a metric is not met under the model. Also, some of these new rules have other changes that are in support of value-based pay outside of the 3 tiers that I've mentioned. There are a couple of other new safe harbors to the anti-kickback statute that I want to mention as well. One is the outcomes-based payment safe harbor, and another is the CMS-sponsored model arrangement safe harbor. I'll touch on the model arrangement safe harbor first. This one's pretty straightforward in the sense that it's a recognition that generally if you're a participant provider in a CMS-sponsored model already, that you should be entitled to some protections in terms of remuneration paid under that model just via engagement in the model itself. So as long as you're meeting the model's requirements, you would be eligible for that safe harbor. The other one I wanted to touch on is the outcomes-based payment safe harbor. And arguably outcomes-based payments have probably always been acceptable from a Stark law perspective with regard to application of a personal services arrangement exception to those payments. But as we mentioned, analysis of both Stark and Anti-Kickback really can inform one another. And so it's a welcome addition drafting in this outcomes-based payment safe harbor to the federal anti-kickback statute to kind of mirror what we've been doing with regard to our analysis for the Stark exception. And that's been drafted into the anti-kickback statute's personal services and management contract safe harbor language as well. Some examples of outcomes-based payments that you're likely familiar with could include, for example, receipt of a shared savings payment or a gain sharing payment, receipt of payment for certain episodic or bundled payments, as well as participation in a pay for performance arrangement. Next slide, please. So I mentioned this consistent vocabulary that has come with the advent of these new final rules and exceptions and safe harbors for value-based payment arrangements. This new terminology can really guide the way that you as a provider think about and discuss, how you're serving the patient, what your overall, value-based purposes and engaging in value-based care. And so it's good to become familiar with this language if you're not already, and I've highlighted here some of these key terms. We think this graphic is helpful in the sense that it really guides you through kind of the key requirements that you need to have in order to take advantage of any of these new exceptions and safe harbors under the new final rules. So there must be 2 or more value-based enterprise participants. So that could be physician groups, other provider entities, or hospitals who establish a value-based enterprise in connection with a value-based arrangement in which the enterprise or its participants then undertake value-based activities. And that can be providing items or services, taking certain actions, or refraining from taking certain actions, where those overall activities are directed at a defined target patient population and the achievement of at least one value-based purpose. And as I mentioned, where all of those elements that I've highlighted here on the slide are met, then you go on to analyze whether or not you've met all of the different requirements under an applicable exception or safe harbor as well. Next slide, please. And so all of the detail with regard to application, these new safe harbors and exceptions is a bit beyond the scope of our time today and talking about cutting edge compensation issues. But our aim with this graphic here is to show at a high level the different columns showing the different types of exception or safe harbor that's available. This one is focused on the new anti-kickback statute safe harbors. And really our aim here is to show whether or not you're meeting each element and each provision is very fact specific, and we'd encourage you to work with your legal counsel to kind of tick through those elements to see once you satisfy the definitional requirements if these different exceptions or safe harbors are available to you as well. And there's some distinctions here that are worth pointing out. We want to note that some of the low to no risk participation options on the left-hand side of the slide do not allow for monetary payments. So there might be some value for an organization to push towards taking on some meaningful level of risk in order for monetary payments to be exchanged between the parties in a value-based arrangement. Next slide, please. And here we've summarized some of the requirements for the Stark exceptions as well. And ultimately for both these tiers in the anti-kickback analysis and the Stark analysis, as participants take on more risk, the requirements to participate do become less burdensome for organizations. So in exchange for taking on more risk with regard to management of a patient population's overall health, there are less requirements with regard to measuring or monitoring certain outcome measures and less burden to your organization as well. Next slide, please. So to wrap up today, we wanted to leave you with a few examples of some application of these new value-based safe harbors and exceptions, just some food for thought, things that we've seen some of our clients raise with us that have required this level of analysis to see if they might be able to take advantage of some of these new value-based opportunities. So the anti-kickback care coordination safe harbor could be applied, for example, if a physician practice would be granted access to a free tool in order to do remote patient monitoring. It would be perhaps like a health system that would offer this free tool, and there would be a two-way exchange of information and two-way telehealth interactions as well. And so we would walk a client through determining whether or not they're able to take advantage of that type of remuneration being offered, and ultimately have concluded that that kind of arrangement could possibly satisfy the requirements of the safe harbor, so long as the technology is used by the recipient of the free tool to coordinate and manage care for that target patient population that, again, has been well defined. Another arrangement that also could fit within the care coordination safe harbor could be, for example, subsidization of internet costs associated with participation in a value-based enterprise arrangement. Again, if this technology that's being offered at no cost is enabling that overall care coordination goal, and that technology is predominantly used in order to further those value-based care activities, it's possible that this would qualify for the care coordination safe harbor as well. And then another opportunity to use this safe harbor that's come up with some clients is, for example, if two practices are coming together and want to jointly fund a care coordinator to provide care coordination services. Again, provided that those elements of the safe harbor are met, we've worked with clients on adding that additional resource to their care coordination team as well. I want to cover also some of a couple of other scenarios that address providers that might be willing to take on some additional level of risk or even full risk. Another scenario could be, for example, utilizing the meaningful or substantial risk exceptions or safe harbors for a physician to be able to take some payment under a bundle of care episode, for example, for a hip or knee care bundle. Those payments to physicians might be covered under an applicable exception or safe harbor, provided that the physician was willing to take on what's defined under the safe harbor exception as a meaningful or substantial level of risk. This varies depending on which exceptions used, but under Stark, for example, that would require a physician to be willing to take on risk for up to 10% of the overall remuneration paid under the value-based arrangement for that bundle. And then finally, I wanted to cover a potential example of utilizing the full risk exception and safe harbor. If, for example, physicians are participating in a full risk Medicare Advantage plan, they could receive remuneration that's protected under these exceptions and safe harbors, provided that they're taking on full financial risk. And in this example, that would mean that the value-based enterprise and participants are financially responsible on a prospective basis for the overall care of a target patient population and for all of the items and services covered by the payer. And that would also be under an arrangement that occurs for a specified period of time. So these are all examples of how organizations, since the advent of the new exceptions and safe harbors that offer these new value-based payment opportunities, have kind of presented options to us for evaluation. We've walked them through the process of analyzing whether or not taking care of or an advantage of one of these opportunities might be right and a good fit for their organization as well. And with that, we're going to conclude today's talk on cutting edge issues in physician compensation. Again, we want to thank you so much for the opportunity to speak with you today. We're very excited working with our physician and provider clients on opportunities that they might have in this evolving healthcare delivery environment to kind of innovate and take advantage of new models. And so thank you again for the opportunity.